All right, Kristyn has her slides up, so if you would go ahead and just give us your case, Kristyn.
All right. So as mentioned earlier, I am the FLS coordinator at the University of Wisconsin in Madison here, and we have a case that kind of spans two of our programs. And we are part of the Own the Bone program and have achieved star performer status in the 4 years that we've been up and running so far. No disclosures relevant to this talk. So our case is an 81-year-old female who was referred to our practice for osteopenia on x-ray. She presented to the Joint Orthopedics Clinic for progressive left hip pain that failed conservative treatment. She was scheduled for a total hip arthroplasty in 12 weeks. And her bone density appeared low on x-ray at the orthopedic office, so they ordered a bone mineral density assessment and referred her to the bone health clinic. So there is the appearance of her x-ray. You can see her left hip has very little joint space, and I do agree that her bones do appear thin. Other relevant history for this patient: she was diagnosed with hypothyroid years ago and has been on replacement for that. Has a history of paroxysmal supraventricular tachycardia. As far as prior surgical history, bilateral cataracts removed with lens replacement, and she had a laparoscopic cholecystectomy in the past. As far as social history, she's widowed and lives alone in a senior apartment. She practices yoga daily and was previously a yoga instructor in her younger years. She participates in a group exercise class 3 times weekly at her senior apartment and walks daily at least a mile. Current medications, fairly short list for an 81-year-old, amlodipine, levothyroxine, and she takes a daily multivitamin. As far as other relevant osteoporosis risk factors, her body weight is less than 127 pounds with a BMI around 22. She has a historical height loss of 2 inches. Upon diet review, has a low dietary calcium intake of about 500 milligrams daily, has no history of adult fractures, and no prior bone toxic medications. So here are the DEXA results she was sent to me with. Her L1, L4 T-score was a negative 4.8. Left femoral neck T-score, which is the hip that is needing to be replaced, was a negative 3.2. Her TBS was quite low in the degraded category, and we wouldn't calculate a FRAX score on this patient because she has T-score osteoporosis, but just for discussion's sake, her MOF risk was 23.8% and her hip fracture risk was 10.9%. What you see on the right-hand side is her VFA, which was very important given her height loss, and there did not appear to be any moderate or severe compression fractures noted. As far as the lab workup we completed, all of her labs, as you can see here, were within normal ranges. So we did not identify any secondary causes for this patient's osteoporosis. So in discussing treatment options with her, we added a calcium supplement to reach her goal of 1,200 milligrams daily. We added cholecalciferol 50 micrograms daily, as our goal for vitamin D level is between 40 and 50. And then, the question really is, what is the first line medication choice for this patient and what kind of weighs into that decision? So we were really considering the leading candidates, either oral bisphosphonate, IV bisphosphonate, bone building PTH-based agents such as teriparatide or baloparatide or denosumab. And, in thinking about our previous discussions here today, we can think about, where does she fall on our ACE guidance, as far as very high fracture risk. So these were the categories that had previously been discussed. And she does in fact have a very low T-score. She's below negative 3.0 and has a very high fracture probability. At her hip, she was above 10%. So you could certainly, consider this patient to start with a bone building therapy because she's considered very high risk. So we did discuss that with her and recommended that she starts Forteo, particularly because she was needing that hip joint replacement. So she started that treatment with no issue, and then 6 weeks later, this is what happened to her. So unfortunately, she had a fall and fractured her, quote, good hip, which was her right hip. You can see the femoral neck fracture indicated with the arrow on the right side there. And she reported that she tripped on her cat rushing to the front door to answer. So after her hip fracture was repaired, she went to a rehab center for 3 weeks to regain her strength. Her left hip was her bad hip that she was having difficulty moving on, and now she broke her right hip, so needed to be able to gain some strength before she could have her hip replacement. And I've run into this multiple times over the last couple of years. The rehab facility would not take her on Forteo. They would not allow that medication as part of her treatment plan at the rehab. Fortunately, her rehab facility was connected to her senior living apartment, and she went home once a day to self-administer her own Forteo because they would not allow her to bring it to the facility. And then she also, had time to visit with her cat, which was definitely helpful in her rehab as well. So she did well and returned home with home health services for a few weeks and was able to have her hip joint replacement about 6 weeks after she returned home. So now she's got hardware in both of her hips, so we can no longer measure the bone density there, but she is doing very well. And again, just kind of, circling back to our discussions from earlier today. So, now she has additional factors that place her at very high risk, with our ACE guidance. So she's now had a recent fracture within the past 12 months and an injurious fall, in addition to her high fracture risk with FRAX and her very low T-score. And then we did have an opportunity to follow up with her recently. And as I noted, prior to her treatment, her TBS was quite low. I believe it was 1.174. And now her TBS is in the normal range after 1 year of her Forteo treatment. Additionally, the bone density of her lumbar spine has increased 11.1% with her 1 year of treatment. She's back to practicing her yoga daily, walking, and doing her exercise class as well. Just a note with my contact information, should anyone have questions after today's session. I'd be happy to talk with anyone who has questions or share email as well.
We do have a few minutes for questions or comments if anybody has comments for Kristyn.
Hi, this is Joe. I have a question. Can you hear me?
Yes.
Yeah.
So, and I'm trying to remember the authors on this. There was a paper about 6 months ago, maybe, from Boston, where they basically, it was looking at what happens after bisphosphonates if you give denosumab or teriparatide. And they said, well, when you give teriparatide, the hip bone density doesn't go up very much and may even go down. But if you give denosumab, it goes up. And the warning in the conclusions and the abstract are, you better not use Forteo if someone's at high risk for hip fracture. I've always assumed that the reason some areas of the skeleton's bone density went down after, if they've been previously treated with bisphosphonates and then given Forteo, was because you were replacing old hypermineralized bone with newer, normal, better bone. And then when you later consolidate that with a bisphosphonate, it goes back up and you have better structure. And I guess I'd appreciate other people's opinion on that. I was very disturbed by that warning. I thought it was not based on anything that made sense to me, but I might be completely wrong.
I'll just chime in that we have a large group of patients who have been on a previous bisphosphonate and fell and broke their hip during their holiday. And we have started them on PTH-based bone building medications, and they have done extremely well with excellent bone density results. We haven't seen major issues after hip fractures.
Neil?
Yeah, Joe, I think you're exactly right. I think that your hypothesis, if you will, of replacing old hypermineralized bone with new, less mineralized bone, and therefore we see it as being less dense on DEXA. I think that makes perfect sense. So I think that the concept of using a more potent anti-resorber rather than an anabolic, that really doesn't pass the smell test of bone physiology. So I agree with your assessment.
I agree. Yeah, thanks.
Okay. Thank you, Kristyn.